Okay, now we're going to start the appendicular skeleton, and we'll start with upper extremity. So again, everything in green is the stuff you're responsible for. If it's not highlighted in green, it'll probably be a feature we talk about, but it's not something that you're going to be tested upon. So the first bone on our list here is the clavicle. The clavicle is commonly referred to as the collarbone. So here we see the clavicle or collarbone. We basically have two ends to the collarbone or clavicle. We have a round sternal end and a flattened acromial end. And so if we come up here to our skeleton, the sternal end is going to be more rounded and it's going to come in contact with the sternum here. The flatter end that we're seeing down in this area is going to come in contact with the acromion process, and that's called the acromial end. As we move into the scapula, there's quite a few bony landmarks that we're going to have to know for the scapula. So the clavicle, all you need to know is the bone name. You do not need to know left or right. The scapula, however, we do need to know left and right, and we do need to know all these features. So we're going to talk about a couple of these first. Okay, in this image, we have a left scapula, and there's a couple of ways that I know that. The first bony landmark on the scapula that we're going to want to be able to find and identify is going to be letter C. So it's going to be 2C on your handout, and it's called the glenoid. Now, depending upon the text, I've seen it glenoid process, glenoid shelf, glenoid cavity, glenoid depression. So we're just going to call it the glenoid because, again, depending upon the text, it's going to say lots of different things. So the glenoid is this kind of shelf-like depression right here. And that is where the head of the humerus is going to come in and articulate. Here we can see a lateral view looking from the side at that glenoid cavity or depression. This is, again, the socket of the ball and socket of the shoulder joint. So the glenoid is always going to be lateral. It's going to be to the outside. And if we come down here, you can see this glenoid's to the outside and this is to the outside. So how do we determine if we have an anterior or posterior view? What I mean by that is the scapula a left scapula and we're looking at the front or back, or is it a right scapula and we're looking at the front or the back? So outside of the glenoid, the next feature we need to find is this spine. So on the posterior or the back side of the scapula, we have the spine of the scapula. Now this is not lettered or numbered on your handout. It's actually 2D, which is one that you don't need to know, but or you're not going to be tested on, I should say. But it is a nice feature to be able to find. So the spine of the scapula is this kind of long ridge of bone, and again, it's going to be to the back side of the body or the posterior side. If I come back up here to our skeleton, if we have this at a 180-degree view, the spine is on the very back side of the skeleton. All right. So from here, we have our spine oriented towards us or posteriorly to the back. The glenoid is to the outside, and then the apex, or also known as the inferior angle down here, is going to be down, right? So if we're looking at this skeleton, we can see the glenoid's over here on this side. The apex is down or facing inferiorly, and the spine is oriented posteriorly to the back. That would make this a left scapula. Again, here we would have a right. Again, if the glenoid was coming to the middle or more medial, then our arms would be in the middle of our chest and we wouldn't be very functional. So in this instance, I have a left scapula. So the arm would be to the left side. This would be along the medial side that we're seeing like this, oriented this way. The apex or inferior angle is down and the spine is to the back. So that's how you determine a left and a right. So after that, let's go through a couple other features. So starting with 2A on your handout, we have the acromion process. The acromion process flares off from the spine. So as we follow the spine out to the end, we have this big flattened piece of bone called the acromion process out here. In a video that I have attached here in a minute, I'll show you the dynamics of why that acromion process is kind of such a key factor when it comes to things like overhand motions like volleyball and swimming and throwing and all those different things. So again, here's just a lateral view from the side showing the acromion process as well. As we slide back up, the next one is the coracoid process. Now from the posterior or back angle, we can't really see the coracoid process that well. It's kind of hidden under here. But as we come more to the lateral side of the front, it's this kind of bird's beak piece of bone coming off to the inside. And if we look at an anterior view, here's the acromion that we just learned, and here's that coracoid process. If you wanted to palpate this, you would basically stick your finger right in the kind of crease of your armpit, follow it up as it becomes a shoulder, and as you push in, you'll feel this kind of bony, kind of almost pressure point type of material right there. And that's so tender because the long head of the biceps tendon is going to come in and attach there. We already learned the glenoid. Again, we had the glenoid. We learned that a little bit earlier. So that is 2C. Here's the glenoid again. As we move down, we're going to have some fossas. And so there are 3 total fossas on the scapula. There is the supraspinous fossa, the infraspinous fossa, and the subscapular fossa. Those are E, F, and G on number 2. So 2 of them have the word spine, supraspinous and infraspinous. The supraspinous and infraspinous are on the spine side of the scapula. Now, infra means below in Latin, and supra means above. So the supraspinous fossa is above the spine, and we find it kind of right in here. The infraspinous fossa, again, below, is below the spine. It's down in here. So again, this is the infraspinous fossa. It's on the spine side. It's below the spine. The supraspinous is above the spine, again on the spine side. If we do a 180-degree view and we come to the anterior side and we move away from the posterior side of the scapula, we find the subscapular fossa. So if I come to this angle, again, my spine is kind of on this back side or this posterior side. So the anterior side, we don't have a spine, and this is going to be this subscapular fossa. We can also see the subscapular fossa here. So both of these images are of a right arm. This one is an anterior view, means we're looking at it from the front, so kind of looking through the chest cavity to the back of the shoulder. This one is we're looking at it at the person's back. So again, spine, supraspinous fossa, infraspinous fossa. No spine, this is subscapular fossa. So that pretty much finishes up our scapula. There's obviously more landmarks that you might see in this image that we're looking at right now. Again, if it's not in green on our list, you do not need to know it for the test or quizzes. So we're going to move into the sternum now. So basically, all you need to know on the sternum is the actual name of the bone. It technically does have 3 parts. The upper portion of the sternum is called the manubrium. The middle portion is the body. This is where you're going to do CPR at if you've ever had a cardiopulmonary resuscitation class or a CPR class. And then the very bottom is the xiphoid process. You don't need to know those terms. I'm not going to test you on them, but that is the way we break it up. Just a little kind of side note, if you had CPR probably 12, 15 years ago like myself, or longer like myself, we used to teach, we found the xiphoid process, we would do 2 finger spaces right here, and then we'd go above it. And the rationale was we were worried that we were going to break this off and puncture a lung, but it's really not true. So really now we just want to be middle of the chest because it's the most efficient. Okay, as we move forward now, we're going to move into the humerus. The humerus, if I bring our little sheet over here, we're going to learn a few different terms on it. So we need to know head, greater, lesser tubercle, and the epicondyles, as well as the deltoid tuberosity. So here we have the humerus, again, making the upper bone. And we need to learn a few landmarks on there. So as we move down, we have the head, which is very obvious, this big round structure that's going to articulate with that glenoid. Anyone want to take a stab at what the actual name of the anatomical shoulder is? Yep, it is the glenohumeral joint. Pretty easy. The glenoid and the humerus articulating together. And then we have these 2 bumps. Again, in a video linked kind of towards the end of this lecture, I show kind of the dynamics of the shoulder. I talk a lot about the lesser and greater tubercle. So the greater tubercle is much larger. The lesser tubercle is obviously smaller, excuse me. They sit kind of lateral, so this is a left humerus. Again, you don't need to know lefts or rights on the humerus for this one, but it is sitting kind of to the outside. So the lesser tubercle is a little bit more forward or anterior, and the greater tubercle is a little bit more lateral. And you might be able to see that if I zoom in on this guy right here. So if we zoom in here, again, you can see the lesser tubercle is oriented more towards the anterior aspect. The greater tubercle is a little bit more lateral. As we move down, before we move a little bit further, there is number 4C is 4D on your sheet is the intertubercular groove or biceps groove. It's not something I'm going to test you on, but one of the biceps tendon, the long head of the biceps tendon sits right here and runs through this groove. So Bicep 2, we'll talk more about that when we get into muscles in the next module. But long head sitting here, short head sitting there. That's why it's called the bicep, because it has 2 heads. As we move down, we have 2 epicondyles, and the word epi means above. So we have the medial epicondyle on the inside, and if you were to feel your own elbow right now, you'll feel this big kind of bump on the inside of your elbow or on the medial side of your elbow. That is the medial epicondyle. It's often one of those things that you hit and you get this kind of zinging sensation down into your pinky, and the reason for that is the ulnar nerve is sitting right behind that, and so we tend to whack that nerve pretty hard and it can cause some irritation. The lateral epicondyle is on the outside. Now, if you feel the outside, you're probably not going to feel this real prominent bump. And there's a reason for that. So as we move into muscles, we'll talk more about this, but all of our forearm flexors, so that the muscles that are flexing our fingers, flexing our wrist, flexing our forearm, like if we're doing, curls and things like that, anything that flexes the hand, wrist, and forearm is going to start and originate on the medial epicondyle. All of our extensors, so the muscles that are going to straighten our fingers and extend them, extend our wrist, extend our forearm, those kinds of things, they're going to start on the lateral epicondyle. Well, you can imagine functionally we're a lot more dominant when it comes to functionality with flexion. We're doing a lot of grasping and gripping and things like that. We don't typically extend and flare our fingers out functionally too much. And so the flexors that sit on that medial epicondyle are largely over-dominating. And so they tend to pull more on that bone, and so that bone is a lot more prominent and sticking out there. And that's the reason for it. So as those muscles have gotten tightened and developed, that bone has responded and grown thicker and larger for more attachment. Because we really have almost the exact same amount of extensors as we do flexors. We have a few more flexors, 2 or 3, but out of about 30 or 40 different forearm muscles, we only have a couple extra that do flexion, and most of them are pretty insignificant to make that much of a difference. So it's just that they're that much more overdeveloped. All right, the last landmark on our upper extremity bony anatomy is the deltoid tuberosity. And we can't see that great right here, but as you can imagine, the deltoid's kind of sitting up here on the shoulder. It shoots over, and then on this kind of outside lateral aspect of the humerus, we have this kind of roughed up piece of bone. It's not very prominent like the medial epicondyle is, or the coracoid process up here, the acromion. And the reason for that is the deltoid has a very wide, large attachment. So it's not coming into one specific kind of point. It's attaching really to almost the entire upper half or upper third of the humerus. So it's kind of got an attachment all along this edge. And so because it's so widespread out, it tends to not pull one specific spot. So that's the deltoid tuberosity, and we can kind of see that, or should be able to see that down here in this image. Apologize for not getting down there fast enough, but this kind of roughed up kind of little bit of bump right there is the deltoid tuberosity. All right, the last 2 bones of the upper extremity that you need to know are the radius and the ulna. And let me pause. All right, I had to find a picture, sorry, real quick, of the radius and the ulna. So here's the radius and the ulna. The radius has more of a rounded head that we can see here. So there's 2 ways that I remember the radius. The radius is on our thumb side. So if you make a thumbs up like Fonzie, those that remember Happy Days, I'm dating myself here a little bit. But if we make a thumbs up, the radius is rad, so the radius is on our thumb side. And it has this round head. The ulna has this big notch, and it is on the pinky side. So if you were going to articulate these bones and kind of line them up to yourself, radius thumb side, ulna pinky side. So here's our ulna on this side, here's our ulna on this side, and then here's our radius and our radius. And if we come up to our big skeleton down here, you can see there's that radius, that kind of rounded head. I'll zoom in here a little bit. Whoops. Rounded head right there on that thumb side, ulna down here on that pinky side. So radial bones, when we're in anatomical position, are more lateral. Ulnar bones are more medial. Again, you do not need to be able to identify all the different landmarks. There are a lot. But for this class, all I care about is if you know the radius and the ulna. It's not an in-depth anatomy. There are a lot more bones of the upper extremity. We have the carpal bones that make up the wrist, the metacarpal bones that are making up kind of the palm of the hand, and then the phalanges make up the fingers. And the phalanges actually have multiple bones within it. So each finger outside of the thumb has 3 independent bones. It has a proximal phalanx, a middle phalanx, and a distal phalanx. So fingers 2, 3, 4, and 5 all have 3. The thumb only has 2, has a proximal and a distal. Excuse me, proximal here and a distal. It doesn't have a middle. None of that you'll be tested on, but I did want to share that with you. Okay, for the last part of this video, I wanted to show a little bit of a functional type of video capturing some of these bones, capturing some issues with the shoulder and different things like that. So again, watch this. I think it's a few minutes long, and it just kind of goes through some of the functional movements of the shoulder and some issues that we have. Definitely nothing in depth, but we'll get more in depth when we get into muscles. Okay, welcome back. We're going to be going through part of the skeleton, and I wanted to show a little bit on our actual upright 3D model here so we can talk a little bit about the upper extremity. So first thing I want to start with a little bit as we pan in here, I just want to talk a little bit about the upper extremity attachment. So if we look here at the anterior view and we come in kind of close, you can see that this is the clavicle coming here, and here is our sternum. This joint right here that we're seeing, especially if we kind of pan in a little bit closer and I bring it closer, this is called the sternoclavicular joint. So here's our sternum, here's our clavicle. This is our sternoclavicular joint that we see here. This joint is the only true bony landmark or bony joint that's holding our entire upper extremity to our torso. If I pan out here just a little bit, and we come to the posterior view, we can see that we have the scapula, we have the humerus, which is part of the upper arm, then we have our radius and ulna coming in here, and then the hand and wrist. So this is what's classified obviously as our upper extremity. Now the scapula doesn't have any what we call ligamentous attachment to the torso or to the thoracic cavity. The way that our upper extremity outside of this sternoclavicular joint is held to the body is by musculature. And that's kind of a key important concept to know. As we move the shoulder and we go through motions, and we've talked about those motions already, like flexion and extension, internal and external rotation, abduction, all these different things, the majority of those motions take place right here at this joint. When we come to the anterior view here, they take place right here at this glenohumeral joint. So this little kind of socket right here is the glenoid. This is the humerus, and this is the ball and socket joint. You can see this kind of head, round-shaped structure coming into the glenoid right there. So again, the majority of those motions, if I stand back, flexion of the shoulder, abduction to the side, so forth and so on, are coming from that glenohumeral joint. What can happen is we can get a condition called scapular dyskinesis. And again, this isn't an advanced anatomy class, but I think these are general concepts that coaches, personal trainers, and things should know because it's something that we see commonly. So if we have a weak bundle of muscles, and we'll get into muscles in the next week and next module, we can have a lot of issues with this scapula holding down and adhering to the thoracic cavity and to this kind of thoracic rib cage. And so we need to make sure that these muscles are strong. That's where your rows and things come in. Again, we'll get more in depth into that when we get into the musculature in the next module. But for now, I wanted to focus on just the bones. So I'm going to go back to my computer here in a minute, and I'll show the rest of those bones kind of in images. There's one last thing I wanted to show on this image, and we haven't covered all these landmarks yet. So I'm going to zoom in here just a touch and come down. So I don't know how well you can see this on the video, but basically right here, this is called the acromion process. It's part of the spine of the scapula, and it kind of flares out into this wide piece of bone right here. This is sitting on the outside. You can actually palpate and feel that on the outside of your shoulder. So if I slide a little bit here and kind of get in frame, this kind of bony part on the top of your shoulder right there, that's what you're feeling. You're feeling this acromion process right here. As we move down, this is the head of the humerus that you can kind of see right here in the image. Now there's two bumps. There's a bump right here that's much smaller. That's the lesser tubercle. And then there's this much larger bump called the greater tubercle. When we do a throwing motion, like throwing a baseball or internal rotation or whatever, when we're kind of in this horizontal plane, you can see how this joint space right here starts to close down. I'm going to back the skeleton out so I don't hit the camera. But you can see how as I abduct the shoulder to the side, that joint spacing significantly gets reduced. Now this greater tubercle that we showed, as I rotate in and out, do you guys see how it wants to grind on that acromion? So you can imagine a throwing motion where I'm throwing a baseball, sorry that's in the frame, how right there when I'm in that internal rotated position, that greater tubercle kind of wants to grind across part of that rotator cuff that's sitting in there. And we'll talk more about that again when we get into muscles. But I did want to show that for right now. I thought that was an important concept to talk about when we go through the anatomy.